Welcome everybody to tonight's Endo A&P webinar. We are joined by Dr. Amy Tung to discuss the fourth trimester postpartum endocrine fluctuation and the impact on women's health. Dr. Amy is a board certified naturopathic doctor who is practicing in Ontario, Canada. She's certified in IV therapy and bioidentical hormone replacement practitioner. She's a wellness advocate and a corporate health speaker. She's been in practice for more than 14 years, and her passion is stress reduction and wellness in order to balance hormones. She graduated from CCNM in Toronto, and before that had a Bachelor of Science from the University of Waterloo, and so she's always had an interest in science, and that kind of brought her to the natural health world. She has a special interest in functional endocrinology, so kind of hormone concerns for all populations, men, women, and children, and then being able to use her naturopathic tools of nutrition, botanicals, acupuncture, diet, and lifestyle to help teach and educate her patients in those areas. And in addition to that, she is a wife and a busy mom of her original bio had 2, but I believe now it's 3 young children. So she's constantly trying to find the balance between, work and life, as we all are right now as well. So without further ado, I will pass the floor over to Dr. Amy.
Thanks, Corey. So 2 to 3, and if you saw my little Instagram video, I had my youngest, who is 11 months, and she was asleep, but I think I just heard her crying, so hopefully she'll be quiet so you can hear me talking. So I'm just going to turn my video off because I don't like looking at myself when I'm doing a presentation. So thanks for having me. I just want to say I have no disclosure, no competing interests. We're going to go through a lot of information, so I'm going to try to go as quickly as I can, but if I'm talking too quickly, Corey's going to send me a little message. So, and you will get all the slides. I think they're uploaded either tomorrow or the day after, so you will get everything here. So our learning objectives, we want to go over some of the hormone fluctuations that are happening in women. So specifically, we're going to focus on the estrogen, progesterone, HCG, oxytocin, serotonin, prolactin, and cortisol. We're also going to talk a little bit about the pregnancy hormones, because I think that's really important to understand the pathways and how the hormones are working, and to understand this huge shift that happens essentially almost immediately the moment a baby is born. Then we're also going to talk about some of the risk factors, assessment tools. We'll have treatment options, both allopathic and naturopathic, as well as time for some Q&A. So let me just advance my slide there. So when I was doing research for this presentation, I came across an interesting term that I had never heard of. It was the word matrescence, and it was actually a anthropologist, a medical anthropologist by the name of Dr. Raphael, who coined the term in the 1970s, and she described it as the hormonal, physical, and emotional transition that occurs when we become mothers. And she also coined the term, and it was later kind of brought to light again 50 years later, actually, by this other psychologist, Dr. Athen. And she actually described it as the evolution of a mom, or essentially the developmental passage that a woman has to go through from preconception to pregnancy and to birth. But I like this definition because it also includes surrogacy and adoption. So what it encompasses is not only the physical, but the emotional changes that women go through as they become moms. And she likened the term matrescence. So think of matrescence to adolescence. And she described it and compared it to the hormonal changes that teens go through during puberty, to the hormonal shift and also the identity shift that we go through as women to become moms. So I found that really interesting, and I found it also important topic for us to talk about, because I think postpartum mood disorders, there's actually a huge gap in terms of the treatment of moms in the postpartum period. And we're going to go into that, but I do think that as naturopathic doctors, we're positioned perfectly to help support our new mom patients, to give them the proper care and the proper follow-up that they sometimes are not going to get through the regular OB or even their midwife. So just to give you a little bit of historical context, the postpartum period and in history and in different cultures, like I can speak to my own ethnicity, being Chinese, that there's actually a specific time that the mom is supposed to be resting immediately after she has a baby. And there's certain meals and foods that are prepared that my mom personally prepared for me, for all three of my children when they were born. But in different cultures, we look at the postpartum period as something that is cherished and something that is pampered. The woman is not meant to feel inadequate or guilty. And interestingly, back in the day, I guess when women lived in the village, right? We know it was the village that took care of them. It was their moms, their sisters, their aunts, their cousins, their extended family, but also other women in the village who had children and had experience. So we had a lot of support in that way, and we had a lot of different teachers. I would say now in North America, we're a lot more isolated. We don't have that support typically. We maybe have just the partner, and if we're lucky, we have an extended family and friends that can support us. During this COVID time, it was interesting because I think a lot of moms went through a time of isolation where we may have had a lot of support previous to COVID, but during this time of self-isolation, we weren't able to have, the same amount of people to come and bring food and to support us in different ways. So we maybe had to look for different ways to look for support. And I think there were a lot of moms who kind of suffered in silence because there really was not a lot that they could do. The transition that we talked about with matrescence is interesting because we talk about the evolving mom and the movement from an old to the new self being born. And I think that this sitting in period, or this period of rest, is a time for the mom to essentially come to terms and to heal, but also to recognize this movement into the new identity that she now has as a mom. Matrescence, also interesting enough, actually can last a lifetime. So it's not necessarily just during the postpartum period, which is the 3 months, which we are calling the 4th trimester. After a baby is born, the psychologist actually says it lasts an entire lifetime for a mom. So some of the hormones that we're going to talk about in the 4th trimester are really important because we know that there is definitely a hormonal role when it comes to perinatal psychiatric disorders. There is a lot more research, I would say, in the last 20 years, but there still isn't a precise cause. And I would say a lot of moms are still looking for answers, so it's important that we continue that research. We know that pregnancy is a huge stress on the body for the mom, right? Your cortisol levels are going to increase without a doubt, and that's the natural progression of pregnancy, right? Babies are efficient, quote unquote, parasites. They essentially will get whatever they want. So if they need certain nutrients, they are going to get that from the mom. The mom, maybe not so much. If she's not able to replenish her stores, she can get what we have coined postpartum depletion, which was actually a functional medicine doctor, Dr. Serelek, who wrote a book on this exact term called postpartum depletion. And he talks about the mom being depleted, essentially, not just of nutrients like calcium, magnesium, and all the minerals, but also of hormonal depletion. So when we talk of rates of postpartum and just looking at the statistics, so in Canada, they estimated it's 1 in 6 women are going to be diagnosed with some form of postpartum depression. In the US, they say around 1 in 8 women, according to the CDC. But depending on what state you live in, it could be as much as 1 in 5. So the statistics are pretty huge. So in Canada, like approximately 10% of women, that's about 40,000 women per year who can suffer from some form of postpartum depression. So the statistics are there. This is a public health crisis, and we need to address it. And the reason why it's important, so we're also we're obviously interested in the health and well-being of the mom, but we're also important for us to look at the health and well-being of the infant and also the next generation, right? So when you think of postpartum depression, essentially the definition, what you want to do is think of major depression, or MD, And then you also have specific symptoms that are related to the woman in the postpartum period. So these are symptoms like, for example, crying more often than usual, anger, withdrawal from your loved ones, feeling numb or disconnected, worrying that you may hurt the baby, feeling guilty, that you're not able to care for your baby. I will also add that according to statistics, and this is a really sad statistic, that suicide is the #2 cause of death in women postpartum. So obviously in the postpartum depression cases, it can lead to that. So that is something that we're going to look at. And if you do identify, it's really important that we have the proper tools to refer and also to assess that. So what's associated with the risks of postpartum depression? So I talked about it being a public health issue, but also from the health of an infant, it can increase the risk of premature birth with low birth weight. It can affect bonding issues with mom. It can affect sleep and feeding issues with the baby. Long term, we don't really know it. There could be cognitive, emotional, developmental, and verbal deficits and social changes in the baby, right? So we have a lot of factors at play and a lot of areas that we need to be concerned with. So just to make that distinction in terms of definition, perinatal depression is similar, but it's a little bit more all-encompassing. So it is a mood disorder, but it affects pregnant and postpartum moms, right? So it's a little bit more general, whereas postpartum depression obviously focuses just on moms during the postpartum period. So a lot of the symptoms will overlap. I'm not going to go through them. Slides are there for you. I had one of the other board members review my slides, and she mentioned a good point, like make sure you put in the DSM rating, DSM-5 rating for postpartum. And interestingly enough, the DSM-5 doesn't actually recognize postpartum depression as a separate diagnosis. It's actually part of a wider diagnosis, essentially, where there's specific major depressive episode that has to happen. They call it an MDE, with an onset in pregnancy that is within 4 weeks of delivery. So we're going to talk about diagnosing PPD and the differentiating it from like baby blues and things like that. But often PPD doesn't happen within the 4 weeks of delivery. It can happen 6 weeks, sometimes 3 months, and even up to a year after a baby is born. So the diagnosis in the DSM-5 is a little bit limiting, I would say, and a lot of psychologists would actually agree, and women who do treat women in the postpartum period say the DSM-5 needs to be changed to recognize this. One of the tools that I think is really critical for all clinicians to have in their practice, especially if you treat moms in pregnancy and in the postpartum period, it's called the EPDS, or Edinburgh Perinatal Postnatal Depression Scale. My midwife actually gave it to me, I think only with my 3rd pregnancy. I don't remember getting it with my first 2, but it's a screening tool. Essentially, it's just 10 questions. The 10 questions are rated, and you add the sum of the score together. When you can give the questionnaire depends. So some doctors actually recommend within the 28 to 32 weeks in pregnancy. So for all pregnancies, not just a woman's first pregnancy. And then again, 6 to 8 weeks later. There's different recommendations. I would recommend that you do it definitely in pregnancy in that time period, but in the postpartum, you can even do it within the first week of having baby. And I'll talk about why. If you are a health professional, make sure you're giving the questionnaire to the patient and she's not doing it alone. So you can do it with them or have them do it in the waiting room while they're waiting to see you. If you're only seeing patients virtually, maybe have them do it with their partner in the same room, kind of things. Because I think some of the questions, if somebody is in a deep depression, they can be quite hard for somebody to answer, and you want an honest answer from them. The other thing is, in terms of scoring, we're going to go over what it looks like. So essentially, this is the perinatal EPDS score. So 10 questions. The last question, any thoughts of harm to yourself? That is a critical question. So if you have a total score of less than 8, they say depression is not likely. If it's from 9 to 11, it's possible that the patient has depression. They recommend continued support and rescreen in another 2 to 4 weeks. And I would definitely consider to primary care provider if you're not able to help them. If they score between 12 and 13, it's fairly high possibility, I should say, of depression. They recommend monitoring, support, and offer education. And then if it's 14 or higher, it's considered a positive screen and it's probable depression and definite referral to specialists, I think. But I would also say that if, say, a woman scores in the 12s and 3s, 12 to 13, and you're not entirely sure, I would definitely err on the side of caution and still recommend a referral. That last question 10 that I mentioned, if it's a positive score, whether it's a 1, 2, or 3, it is an immediate referral. And as a clinician, if you are the person in contact with that mom and you have this information, it's your responsibility to give that proper urgent referral as soon as possible, and also to follow up. So really critical that we take this seriously. As I mentioned, that sad statistic that suicide is the #2 cause of death in postpartum women. So when is the best time to screen? So they actually say if you screen within the first week, you can actually predict the likelihood of a woman developing postpartum depression within 4 weeks. So I actually recommend that women be screened earlier, and then you can actually do it multiple times. So there's not really, I wouldn't say there's a bad time to screen. If you're not sure, I would say just do it. So they actually say within 2 to 3 days postpartum. Some of the risk factors for postpartum depression. So thyroid concerns. Postpartum thyroiditis is the most common endocrine condition in postpartum women. Hashimoto's and hypothyroid, a history of it prior to pregnancy, during pregnancy, can increase your risk for postpartum depression. So it's important that we do proper screening and proper history. You also make sure you screen for any major mood disorder. So during adolescence or prior to pregnancy, like make sure you do that thorough history. Assess their stress level. So did they just have a recent divorce, for example? Did they just lose their job due to COVID? Have they just moved? Are they a single mom? Did they have a certain idea of their birth being, like, for example, a home birth, and they wanted a water birth, but then suddenly there was meconium, they had to be rushed to the hospital for emergency C-section, or whatever that specific idea of the birth was. And if it was completely opposite, that can definitely be a stress for new moms. What is the socioeconomic status, right? So again, we're talking about trauma, any type of trauma, any type of high stress or anything like that. High levels of testosterone. So the research has said that if you screen moms that are high risk for postpartum depression within the first 24 to 48 hours, and they have high levels of testosterone, they are also at increased risk of developing postpartum depression. Low oxytocin during labor and afterbirth. So this is typically, I would say, in women who are induced. Women who are induced are given Pitocin IV, which is a synthetic of oxytocin. And I think the theory is that if they're given Pitocin, their body is not able to make the endogenous forms of oxytocin to stimulate contractions. So I'm not saying that women shouldn't be induced. I'm just saying that women, when they are induced, you need to be aware that it can increase the risk for postpartum depression, but not always, right? What is their sleep like? Are they shift workers? How is that going to affect their sleep once they have the baby? Any other history of hormonal imbalance like PMS, PMDD? What is their support network like? Do they have a quote unquote village? Do they have people that they can support? What is specifically a partner or even their extended family or friends? A lot of patients, when they are having their first child, they go kind of from, being single and then being a couple, and then you kind of, when you're single, you have a lot of single friends. When you're married, you have a lot of married friends, and then you don't hang out with single friends. When you're married with a kid, you don't always have a lot of friends that are single or just couples without kids, right? Obviously it would depend, but sometimes you don't have the friend support that you used to have. And also family history. So did your mom have any history of depression or postpartum? The hormone decline, a rapid decline of estrogen and progesterone. So we're going to talk in detail about that, but essentially it goes from super physiological levels in the thousands and then immediately crashes and tanks to levels that we see in menopause. So these huge fluctuations can make women who are more predisposed to depression even more sensitive, right, to that change, and lifestyle contributors. So I'm not going to talk too much about all the different mood conditions, just know that there are different ones, specifically baby blues, and postpartum anxiety, postpartum depression, which we will focus on, postpartum psychosis, and then there's also postpartum depression that has been studied in dads. And this is typically in new dads who have a history of depression, can be triggered, right, when they have a baby and probably not getting enough sleep and all sorts of other things. I'm not going to talk about the dad component, but just know that that does exist. What's the difference between baby blues and postpartum? So baby blues is, it typically only lasts a maximum of 2 weeks, and the onset is much quicker. It's usually within the first 2 to 3 days, sometimes within hours of birth, but it can affect up to 85% of women. All right, and so I would say most women go through some sort of blues, especially the first 2 weeks, because of that crash in estrogen and progesterone. Whereas postpartum depression is different. It starts within 1 to 3 weeks after birth, but typically within the 4-week period. But again, like I said, it can happen anytime in the first year. The feelings of sadness are more intense, and there's much more anxiety, and that feeling of hopelessness is magnified much more than just typical baby blues. And it lasts much longer, sometimes months, sometimes a year or longer, and it does typically require treatment. So just remember those two differences. So you're more likely to see baby blues, I would say, because it's 85% of women. Postpartum anxiety, I'm not going to really go into, but it's essentially an anxiety condition. So it can encompass different types of anxiety disorders. There's also postpartum depression versus postpartum psychosis. And psychosis is more rare. It happens in 1 to 2 cases per 1,000 births. So lot more rare than PPD and even baby blues. But psychosis is defined by somebody who can't tell the difference between what is real and what is not. And it can include thoughts of infanticide and suicide ideation. And it can be associated with socioeconomic factors, but not always. So it is something to be aware of, though, and again, refer immediately if needed. First trimester hormonal shifts. So we know estrogen and progesterone are critical when it comes to pregnancy. If you're helping women in terms of fertility, you know the importance of progesterone, but sometimes we don't always talk about estrogen, right, and the importance of estrogen. So one, it does help initially with the stimulation of ovulation. It helps to thicken the endometrium. And it also helps with the signaling the development of the organs in the baby. So that's why you have, if you look on this graph, this rapid rise, right? This blue line is the estrogen. And that is helping the fetus to grow. One thing that I want you to know in terms of initiation of labor, estrogen is what, when estrogen increases, it increases the contractility of the smooth muscle. So it actually stimulates the uterus to contract. So as you see, as a woman enters closer to her 3rd trimester, estrogen actually goes up even higher because you're getting ready for baby to be born and for the uterus to contract. Progesterone, also critical. It aids in the implantation of the egg to the endometrium. It helps the body and tells it to stop menstruating when you're pregnant. It also is protective to the endometrial lining, and it reduces the rejection of the embryo because it's involved in the immune response, which we're going to talk about. And important in terms of birth is that it decreases the contractility of the muscle. So it works opposite of progesterone. So as a woman gets closer to her due date, progesterone actually starts to go down a little bit, and that's a signal to start contraction. HCG, human chorionic gonadotropin, when we do a urine pregnancy test or a serum pregnancy test, we're measuring the beta HCG, which is a subcomponent of HCG. HCG is initially actually produced by the trophoblastic tissue, and essentially the trophoblastic tissue will become the placenta and continue to grow and help the progesterone production. So if you look at the red here, this is the HCG levels. They peak typically around week 9, and then they really start to come down. A positive pregnancy test obviously tells us that the egg is developing properly, but it also stimulates the corpus luteum to produce progesterone, and then progesterone production will happen in the placenta after week 8 or 9. Just to look at the hormones, so when you look at estradiol, like look at prepubescent levels, they're less than 10, in a male less than 60. In a female who's ovulating in an early follicular, we're looking at 3 to 100, late follicular 100 to 400, luteal 60 to 150. In a pregnant female, you're looking first trimester 188 to almost 2500, second trimester 1278 up to 7192. So super physiological is what we're calling it. Third trimester around 6,000, and it can drop a little bit down to 3,000. So a huge, a very huge shift in estradiol levels. Postmenopausal levels go down to less than 18. Progesterone in a menstruating female, so pre-ovulation less than 0.2, at ovulation less than 12, post-ovulation between 3 and 20. First trimester progesterone between 8 and 48, second trimester up to 89, third trimester around 342. So you can see how the levels are really going up quite steadily throughout the pregnancy. Why is progesterone important? So just remember these two things, the maintenance of the pregnancy and the implantation of the egg. So we need progesterone to be elevated, right? We need that level of progesterone to rise continually throughout the 3 trimesters in order for the fetus to grow and for implantation and to prevent the rejection of the trophoblast, right? The other thing progesterone helps with is that it pushes the body into a Th2 cytokine response. So you're going to get increased interleukin-6 production and interleukin-4. And that helps the body to maintain the pregnancy. So the Th2 dominance is critical for implantation. So basically we don't want to reject that embryo. The HCG levels, I just wanted to show you from embryology in case you forgot. So the trophoblasts are the outer casing of the blastocyst, and they actually become the placenta, whereas the interior embryonic stem cells become the embryo. So when we're measuring the beta HCG, this is just to give you the visual. It peaks around anywhere, they say between 9 and 12, week 9 and 12, and then it drops. Low levels of beta HCG can indicate an ectopic pregnancy. Beta HCG levels that go even higher than this can sometimes indicate multiple pregnancies, so twins or triplets. But we also use beta HCG when we're screening for malignancies. So in men, testicular cancers, and in women, certain teratomas and ovarian cancers. When it comes to hormones and the initiation of labor, so what we're looking at typically, so I mean, women know this, when you have your due date, a lot of midwives actually call it the guess date, because your actual due date could be anywhere 15 days before or after that date. The initiation of labor starts from the fetus, which I found interesting, because a lot of times when we're trying to get moms to be in, to kind of progress in terms of delivery, we're like, eat dates, have spicy food, go for a walk, have sex, like all these things are great, but it's actually the fetus that will initiate the delivery. And essentially it starts when the baby's like, I'm getting too squished in here, I need more room, and it starts to stretch on the uterus. That's what triggers it, and then it starts to produce, the fetus starts to produce cortisol. Also in terms of increasing estriol from the placenta. So remember that estrogen will increase to cause contractions, and progesterone will decrease. So this is starting the contraction process. Estrogen will also cause the formation of oxytocin receptors on the myometrium, and that's important because of, remember how I mentioned how women who have low oxytocin are at more risk for PPD? This is why, because they're given the synthetic Pitocin, so their body is not making the oxytocin receptors on the myometrium, right? So it's not responding in the same way. As labor gets closer, you get oxytocin and prostaglandins, which also increase uterine stimulation. This is just the chart form. So this is at the fetal level, so you get the maturation of the hypothalamus, triggering the corticotrophin releasing factor. That triggers the pituitary to release ACTH. That triggers the adrenal cortex to release cortisol. And then the cortisol from the baby will trigger in the placenta decreased progesterone, right, which is going to start increasing contractions, and also an increase in estrogen, specifically estriol from the placenta. And that will also increase the prostaglandin production. And all of these are going to increase the myometrial contractions in the uterus, so the muscle contractions. And then that sends a signal to the posterior pituitary of the mom to increase oxytocin. And then you get further stretching from the baby, the fetus, on the cervix and the vagina. And that also kind of increases a positive feedback loop, and oxytocin levels start to increase and contractions will start to progress further. In terms of immune dysregulation, so we know that the body shifts from a shifts to a Th2 dominant state in pregnancy. Immediately following the birth, the body shifts back to a Th1 pro-inflammatory state, and that state actually lasts for a few weeks. So this is important. There's actually more inflammation in the body immediately after delivery, and for a few weeks after, right? Patients with depression, they tend to have higher levels of pro-inflammatory cytokines, so TNF-alpha and interleukin-6. The role of the immune function isn't super clear, but we know that it does have an interplay, especially in women who have an autoimmune condition, especially if it's a Th1 dominant immune reaction, because the body's shifting back to the Th1. All these changes in hormones can cause stress on the female, especially if you're susceptible. I'm going to talk a lot about the cortisol and the immune shift from Th2 back to Th1, which essentially what it does is it drives tryptophan. Tryptophan is the amino acid, right, which converts into serotonin and then melatonin. What happens is, because of the increased inflammation, you're getting that drive down this pathway, and you're going to get the end products, kynuric acid and quinolinic acid. These are neurotoxins, and they're not something that we want. So you can see here the IL-1 and IL-6 and TNF, they're actually increasing the IDO enzyme. And cortisol, your stress hormone, is also going to increase the tryptophan dioxygenase TDO enzyme. So you're actually, immediately after birth, you're causing more of a shift down this pathway, right? As opposed to tryptophan to 5-HTP to serotonin to melatonin. The other interesting thing I want to point out, there is a rate limiting step in the tryptophan to 5-HTP conversion. It's by tryptophan hydroxylase 1 and tryptophan hydroxylase 2 enzyme. The 1 is found mostly in the gut, and we know that 90% of tryptophan conversion happens there, and the 2 is found in the brain. So this is a rate limiting step for tryptophan to convert to 5-HTP and to go down that pathway we want it to go. The other thing that's interesting is that what upregulates the TRPV1 and 2 is estradiol. And we know that estradiol levels tank right after birth. So you're getting this huge influx of inflammation, a huge rise in cortisol, a huge drop in estradiol. So it's not really a surprise that women are kind of going down this pathway towards more of a depression as opposed to this pathway, right? The other thing to note is, for tryptophan to convert to 5-HTP, we actually need all these important cofactors and nutrients. The most important, I would say, iron. And iron is probably one of the most common minerals that women are deficient in, especially after labor, especially if they've had any kind of blood loss. But also B6, folate, calcium, magnesium, omega-3s, and vitamin D. 5-HTP will also need cofactors, B6, zinc, magnesium, vitamin C, to convert to serotonin. And then serotonin will convert to the active metabolite, melatonin, right, in darkness and with no blue light. The other thing that is interesting to note is serotonin can be inactivated into this inactive metabolite we call 5-HIAA. How it's inactivated is by this MAOA enzyme. Just remember MAOA, I think of it like the gas or the brakes. Essentially, if levels of serotonin are good in the body, it will essentially, or sorry, if they're too high, serotonin levels are too high, MAO kicks in and it's like the gas pedal. It starts to shunt it more towards the inactive form. If serotonin levels are low, MAOA will start to decrease. It starts putting the brakes on. So it's like, don't inactivate serotonin. We need the serotonin. So what influences MAOA but our estradiol? So estradiol acts on these specific two pathways. And so it makes sense that women who are going through mood issues, they have this issue specifically with the kynurenine pathway and the MAOA. So the MAOA specifically, they have done imaging studies and they've found that women with postpartum depression, they actually have elevated MAOA density in the brain. And they know in that area specifically, it's responsible for emotion compared to asymptomatic women in postpartum that did not have increased MAOA activity. So if the MAOA activity is increased and there's increased density, you're getting increase in activation of serotonin when we want the levels of serotonin, right, to be optimal. So there's a whole bunch of things going on, and that's why a woman's mood is hugely affected. In terms of estrogen and progesterone and immune function, so we know that there are estrogen receptors throughout the body, both alpha and beta. They are widely found in our immune system as well. So the T cells, the B cells, and the dendritic cells. And estradiol specifically has a stimulatory and an inhibitory effect on the immune system, right? And we know, as we just went over, it supports serotonin conversion. So it's not a surprise that women, when they shift back to that Th1, they're getting all these symptoms that are going to come out that were essentially suppressed for a lot of them. In terms of Th2 dominance in pregnancy, so Th1 dominant autoimmune conditions, so RA, MS, Graves' disease, Hashimoto's, these typically improve in pregnancy, right? Because we're becoming less inflammatory, whereas the Th2 autoimmune diseases, they typically can get worse during pregnancy. So like lupus and SS. The pro-inflammatory cytokines, just remember, I already mentioned the TNF alpha and IFN, they can induce spontaneous abortion. So that's also why the body shifts to the Th2, because again, we're trying to keep that little baby happy and safe in there. In terms of cortisol and stress, cortisol steadily will increase in pregnancy, but typically right after birth, the levels will start to drop. In women who have postpartum depression, the cortisol levels do not decrease. So they actually did a study looking at the urine cortisol metabolite production in 49 women who had normal pregnancies, and they measured them 12 months after, and they found that their urine cortisol levels were elevated. So we know that cortisol levels are high in women who have depression. So it, I mean, obviously makes sense. Again, this review specifically looked at stress hormones, immune function, inflammation, and the tryptophan pathway, again, which we just talked about, how it affects the kynurenine pathway, and how it lowers serotonin and melatonin production, right? So all of this kind of ties in together. There's a lot of things going on at the same time, but I think it's important for us to understand the whole picture. Oxytocin, we know that low oxytocin, as I mentioned, can be, when combined with high cortisol, can increase your risk for postpartum depression. And I mentioned the Pitocin as well already. Patients who have early life trauma have been studied also just to have lower levels of oxytocin. Oxytocin is our our cuddle hormone or our bonding hormone. It helps the mom to bond with the baby. So if you have low levels, I mean, it sort of makes sense too, right? That you're not necessarily going to bond as quickly with the baby. Looking at prolactin, so if you look at the red here, the prolactin levels again rise just like progesterone and estrogen, right? But unlike progesterone and estrogen, which essentially drop and stay low, prolactin pulsates. So you get this pulsation that goes with nursing. And this is, I think, in 36 weeks after birth. So after parturition is after birth. So you see how prolactin essentially, we know, suppresses the function of estrogen and progesterone. So when we talk about treatment for moms postpartum, you got to make sure you're looking at whether or not that mom is breastfeeding, right? Because if you say treat the estrogen and progesterone to increase it too much, you may suppress prolactin and you may suppress milk production. Postpartum thyroiditis. So we're looking at the high thyroid hormone levels in the blood specifically. And there's actually two phases. So you have the thyrotoxic phase and you have the hypothyroid phase. The thyrotoxic phase is typically the first, lasts about 1 to 3 months, but it starts within 1 to 4 months postpartum, and you get more of like the hyper symptoms of anxiety, insomnia, palpitations, fatigue, weight loss, irritability. And then the second phase is the hypothyroid phase, which typically happens a little bit later, 4 to 8 months after delivery, and it lasts 9 to 12 months, and you get more of the hypo symptoms, right? Like fatigue, weight gain, constipation. Sometimes if you test a mom too in a later phase, you're going to kind of miss that thyrotoxic phase, even though they're losing weight. You might think that they're like hyper, but they're actually hypo, right? They're kind of in that in between. Their presentation, they will have positive anti-TPO and anti-thyroglobulin, so much like Hashimoto's. And this is partly because of the rebound effect, which I talked about, when the body shifts from the Th2 in pregnancy back to the Th1. So Hashimoto's and Graves are conditions that can worsen right after the baby's born. Typical thyroid function will get back to pre-pregnancy levels after 4 weeks, but there are about 23% of new moms that experience hypothyroid symptoms regardless. And just remember that the thyroid, it controls metabolism throughout pregnancy. And it upregulates the metabolism of the baby, but also of the mom. So what can happen is, in some people, the thyroid function is upregulated, and immediately after birth, it doesn't go back down, it stays elevated. It affects 8% of pregnant population, and as I mentioned, it's the most common endocrine disorder associated with pregnancy and postpartum. The risk factor of having an elevated TPO in and of itself in a mom who doesn't have Hashimoto's can also increase her risk of postpartum depression. But if she also has elevated TPO and low T4, she's at an even greater risk of developing postpartum thyroiditis and postpartum depression. There are genetic influences. So specifically, studies have looked at the ESR1 gene associated with the Edinburgh postnatal depression scale, which we talked about. And they found specifically the SNPs on the serotonergic signaling proteins and the dopamine transporter. So SERT and the HTR2A and the SLC6A3, but the dopamine transporter association was a little bit less than the serotonin one, which makes sense, as we had discussed how serotonin and estrogen go hand in hand. So in terms of treatment options, what we're going to look at, so definitely do your proper assessment, do your questionnaire, and also do proper hormone and other nutrient testing. Possible treatment options, so estradiol topical might be an option. We're going to look at some of the research. Oral progesterone, because we know that it converts to the active metabolite allopregnanolone, or allo, which stimulates the alpha GABA receptor, which calms the brain. Topical progesterone cream, important, as I mentioned, because we know prolactin suppresses estrogen and progesterone. If you're going to give these, know that you may affect milk production. So you got to have that conversation with the patient if they are nursing. Serotonin support, look at factors, right, affecting the kynureninic pathway, as we mentioned, nutrient status, naturopathic support, cortisol stress management, and prescription meds and counseling. So let's look at the research when it comes to estradiol. Interestingly, what this study did was they looked at transdermal estradiol at a dose of 50 to 100 micrograms. And they found that at this low dose, it was actually not detected in breast milk. And they also studied that it didn't affect lactation or breastfeeding frequency in these moms in a 12-week period. So I found this study really interesting. So this is definitely an area, I think, of more research. Progesterone treatment, specifically, they looked at, so be careful with progesterone research. I know all you endocrine specialists will know, but a lot of times they say progesterone, but when you read the research, they don't use natural progesterone. It's synthetic, almost like all the time. In this case, it definitely was synthetic progesterone, and they found that it increased the risk of depressive symptoms at 6 weeks when they used the synthetic progesterone. So, and we know we definitely don't want to use synthetic progesterone anyways. Another study where they used 100 women and they gave them intramuscular injections of progesterone at 100 milligrams a day for 7 days after birth, and then they gave 400 milligrams of a progesterone suppository twice a day, a rectal suppository, for 2 months. They actually found that the recurrence of these women with a history of postpartum depression was decreased by 10%. So that's actually pretty significant, I think. The Cochrane review, though, did conclude that there was not enough studies to show that natural progesterone was beneficial for postnatal or postpartum depression. So we do need more studies. I will just add clinically that I've spoken to functional medicine practitioners and that are also OBGYNs, and they actually use progesterone cream, although I couldn't find any research on it, like natural progesterone cream. And what these doctors recommend is a low dose. So they typically start at like 15 milligrams, and they usually dose it at bedtime at the last feeding application. And if they have also done oral progesterone, but they would recommend at like a 25 or a 50 milligram dose at bedtime, because we know oral progesterone will make you sleepy. So again, it might be an option. Again, it's more anecdotal. I couldn't find any specific research on that. But again, make sure you have that conversation with your patients if you are going to work on their hormones, because as it does affect breastfeeding in a lot of patients. Antidepressants. So we know that for MDs, this is the first line of treatment, and it does work. It is effective. There's tons of clinical research with it. Just know that for nursing moms, the first line is sertraline or Zoloft, and the second line is, if sertraline doesn't work, would be paroxetine or nortriptyline. There are a lot of the antidepressants that are contraindicated in moms that are breastfeeding because it transfers into the breast milk. So having said that, there is a little bit of conflicting information in the research as well, because if you look at the long-term effects, I mean, I don't think we really know what the long-term effects will be on a child's cognitive or their motor or neurological or their behavioral development. We don't really know 100% without a doubt. I think if it's somebody who's in a really poor state and they do need an antidepressant, you maybe want to have that conversation that maybe we can get you to pump like a whole bunch and freeze a whole bunch of milk, or even look at formula for a period of time until we can get you to a good place. And that might be where you need to have that conversation with your patient. So it really depends. This medication I wanted to highlight because it literally was just approved by the FDA last year, 2019. It's actually a synthetic copy of allopregnanolone, but it's given via IV. So we know allopregnanolone comes from oral progesterone as a metabolite, and it calms the brain via the GABA receptor. We know that it can definitely help women in perimenopause and menopause. So it sort of makes sense if a woman is deficient in estrogen in postpartum depression, that it could help. It is an IV drug. It's dripped over a 2.5-day period. So you have to be admitted to a hospital or infusion center. The data is mixed as to whether it transfers into breast milk. Some of the data I saw says it's safe, it does not, and some said that it's unknown. I think because it's such a new drug, they don't really know. And they don't really know if it's safe in pregnant women. The question that some researchers have asked are how effective and how long does it last for? Like if you have one treatment through IV, how soon after will you have to come back for a follow-up? Is it in a month or every 3 months? We don't really know. And the cost is pretty high. It's about $35,000 US for one cycle, plus the cost of the infusion center or hospital. So it's not feasible for a lot of people. Postpartum treatment options, obviously counseling is a huge one. CBT and interpersonal psychotherapy seem to be the big ones in the research. Prenatal screening, so for sure do a full thyroid panel, but also check all your other key nutrients, right? Vitamin D, iron, fasting blood glucose, CBC. The 4th trimester testing, again, redo the full thyroid panel, definitely check your iron, definitely check all your nutrients, D, B12, and I would also recommend, depending on the individual, you might want to add other things. Like if a patient suddenly has increased joint pain, you may want to add in like rheumatoid factor. I would also consider doing a urine test, like the Dutch or any dried urine test to look at cortisol. Because it also, what I like about the Dutch is it also looks at the breakdown products of and the metabolites, and it also affects, looks at the neurotransmitters. So you're going to see serotonin. It also checks the kynurenate. So I think it's a good test, and melatonin. So if you really want to get a clear picture of where the patient's at, I think it's a great tool. Just to give you kind of a little idea, this patient of mine, 38-year-old, I had never seen her during pregnancy. First time I'd seen her was 1 year postpartum, and she had never had her thyroid checked by anyone. And she just told me that her mom was recently diagnosed as a hypothyroid. So we checked everything. So look at her TSH, it's definitely not optimal, 3.45. Her antibodies are really high. Her ferritin is pretty low, 43. And her vitamin D is low, not, I mean, in range, but not optimal. So just make note, like my American docs, this range in Canada is nanomoles. In the US, I think you guys use millimoles per milliliter. So it's a little bit different. The optimal range is 50 to 70 in the US. In Canada, it's about 125 to 150. So definitely this level should come up. Ferritin, I like to see it about 65. I had the CBC, but I didn't include it here. So we definitely needed to up her D and her iron and work on her thyroid. Nutrient deficiencies, I have like a whole appendix. I don't think we're gonna have time to go through everything, but know that it all is there. One thing I did wanna highlight is tryptophan. So we talked about the kynurenate, right? And how that pathway specifically affects tryptophan conversion. In this study, it was done in 2017, I believe. They looked at research specifically for postpartum blues, not postpartum depression, but they gave these women 2 grams of tryptophan, 10 grams of L-tyrosine to help with dopamine and norepinephrine, and they also gave them blueberry juice with blueberry extract on days 3 to 5 postpartum. And what happened was they actually noticed an increase in mood. So just overall, that postpartum blues period improved. So that was, I think, pretty significant. My only caution is, as we have discussed, if you're going to give tryptophan, make sure you're also supporting the body to move down this pathway, right? So you got to address the inflammation and you have to address the cortisol. You may want to look at just tryptophan-rich foods. And in terms of inflammation, just side note here, there's the microbiome, and the gut is a huge factor when it comes to inflammation. Breast milk, specifically for the baby's pathway conversion, they have found that it will decrease this inflammatory pathway down this way. So having the mom take a probiotic is probably a good idea, and for herself and also for her baby. But definitely, if you're going to do tryptophan, look at treating the whole person. So I'm not going to talk about all the herbs, but just know probably the most extensive in terms of historical use is the Leonaris or motherwort. So obviously motherwort makes sense. Historically, it's probably the most common herb used for postpartum depression, anxiety, and with palpitations and stress. It's a nervine, it's also an emmenagogue. So I think it's a great herb. It is contraindicated in pregnancy though, so just be aware of that. Passion flower might be another option. It's considered safe in lactation, motherwort is also safe in lactation and also long history of use. So that might be, those two probably would be a good option. What we're also gonna look for, oops, sorry. Did I make a mistake? Oh, okay. I think I have a herb or another herb. I don't know. It got mixed up here for some reason. Anyways, further naturopathic support. I only have a few more minutes here, so I'm going to try to fly through this. Nutrient status. So we talked about, but specifically your vitamin D, your zinc, iron, B6, and omega-3 supplementation. And I often get women to do a prenatal just to have them continue it at least for the 3 to 6 month period, even sometimes up to a year if they're really depleted. I think it's a good idea. Make sure they're hydrated, especially if they're nursing, because you need that water, you need that fluid to produce breast milk. Focus on nourishment, really really deter your mom patients to lose that quote unquote baby weight or detoxing. Like you don't want to do that at all during the postpartum. Any type of movement, look at the adaptogens, massage, yoga, meditation, help them to get some more sleep. If it means getting, you know, pumping and having dad do a night shift so the mom can do a little bit of a longer sleep shift, I think that's a great support for mom to get a little bit more sleep. And look for professional help if you need it. I'm sorry, this is what happened. I think one of the slides got mixed up. St. John's wort is another herb. It has a lot more contraindications, so just be more careful with this one. And it is limited in terms of studies with postpartum, but I just put it in there because it's that big depression herb that we know of. Other adaptogens are ashwagandha or withania. I probably wouldn't use this in a patient with any type of thyroid condition because we know it can stimulate thyroid production, thyroid hormone production. It is safe in lactation, but just be aware of the person that you're giving it to, right? Make sure you check their thyroid. Schisandra and saffron are other herbs that have been studied. Look at the omega-3 status. So the studies have shown women with PPD, they have higher levels of omega-6 and lower levels of omega-3. Iron, we've talked about vitamin D and also zinc, really critical. We know these are also cofactors, right, in tryptophan conversion. Magnesium and also selenium and folate. These are all critical nutrients. Prepare your mom. So one thing that I think is important, if you have a patient and you are seeing them during their pregnancy, make sure you try to have that open dialogue or that conversation, like what we talked about in terms of matrescence and that identity shift. Maybe look at breastfeeding support for them. Consider and talk about what is considered quote unquote normal behavior for a baby, because a lot of moms have absolutely no idea if they don't have any friends who have babies. It's a complete shock for them. Talk about your support, nutrition, diet, blood sugar balance. If they've had any history of miscarriage and you're seeing them when they're pregnant, just make sure you talk to them. Is there any depression or anything associated with that? And in terms of postpartum visit schedule, I found this really helpful. This was the American College of Obstetricians and Gynecologists. They had a symposium and they proposed this new postpartum visit schedule, which I think is a great tool. Take a look at it. It basically recommends that you do more continuous follow-up, is essentially for up to 4 to 12 weeks, individualized and woman-centered, and more thorough follow-up, because I think we need that. So my critical takeaways, make sure you're looking at the whole person, which we know as NDs, right? Look at the cortisol, look at the estrogen, look at progesterone. We know that those specifically crash essentially right after you give birth. Look at the thyroid, serotonin pathways. Remember I mentioned the study with the high testosterone. So if you have a woman who has had a history of PPD, check their levels within 24 to 48 hours. There are genetic influences, so maybe doing genetic testing if that's something you do. Nutrition, lifestyle, diet. Thank you for listening. I think I'm right on time. So I think we're open for some Q&A, Corey.
Perfect. Thank you so much, Dr. Amy. Yes, that was literally to the minute on time. Beautiful. Yeah, so it's time for some Q&A. So for those of you who joined after we officially got started, might have missed my initial instructions, but you can type questions in that GoToWebinar control panel, or even better, because it adds a little bit more interactiveness, if you want to raise your hand, there's a little hand icon, and you can raise your hand and I can unmute your line individually, and that way you can ask the question verbally, which might make it easier than typing it all out. So I will give people a moment to do that while we are looking here, because I know sometimes it takes people a few seconds to write questions, and that was a lot of information provided. And again, as people might be typing, if you missed it at the beginning, we'll be posting the recording as well as the slides for tonight's presentation on the EndoAMP member site tomorrow. I'm going to say tomorrow out loud, and so therefore it shall be done. Let's see here. Not seeing any questions yet, but like I said, I'll give it a couple minutes in case people are mid typing. I don't want to end the webinar and cut them off. Oh, I got a comment, so I'll share the comment. It says, "This was amazing, Amy. There's so much information to process."
It was a lot of information.
Oh, great. Kara, I'm going to unmute your line. I see your hand up here. Let me just unmute you. Okay, Kara, you should be able to ask. Oh, you put your hand down. Then maybe I unmuted you. Let's see here. Oh, no, it's just another comment. So nice to hear your voice for an hour, Amy. Thanks for the amazing talk.
Thank you. If there are questions, you can also, on our Facebook group, you can post them, and myself or any of the other members can also contribute. So if you think of something and you don't want to ask or you're not sure about, you can always post it later.
Great. Oh, and I see a couple things. I see a hand up. So, Lee, let me unmute you. Dr. Gu. Okay, you should be able to say something out loud. Oh. Dr. Gu, I think you should be, there you go. Yeah.
Can you hear me now?
Yep, we can hear you now.
Well, thank you, Dr. Amy. That was a very informative webinar. The question I had was, do you have a range that's optimal for specifically postpartum women in terms of their serum vitamin D levels? I'm used to working with oncology patients. I have one, but I don't know if that's any different for this population. Thanks.
Yeah, so I know in oncology it's typically a little bit higher. So like I said, in Canada, I just want to make sure I get the measurements correct, because I know the values in Canada are a little bit different than in the US. And sometimes when you hear webinars, depending on where it's presented, it kind of throws people off. Like I typically like my patients in about 125, 150 range. And that's Canadian.
Well, that's perfect. I'm Canadian, so it works for me.
Yeah, so I don't know in terms of oncology, I know it's probably similar, if not higher.
Yeah, that's the same route. Thank you so much.
Yeah, no problem.
Great. The next question, comment, just might have missed this. Yes, this is being recorded, so if you missed any of this, it'll be on the website tomorrow. I totally understand kids making noise in the background, so no worries there. Great. And Nyla, I saw your hand up, so I'm going to unmute you in case you have an additional question, or maybe that was just it, but I'm going to unmute you and see if you have anything else. Let's see there. All right, Nyla, you should be able to unmute yourself if you had a question, or maybe you just had the comment. There you are. Or at least the microphone's green, although I don't hear you.
I also wanted to say, in case for Dr. Lee's comment, so I saw, sorry, in Canada it's 125 to 150 nanomoles per liter. In the US it's 50 to 70 nanograms per milliliter. So just that distinction. That's why it depends on the values and what you're looking at in terms of, that's vitamin D, serum vitamin D.
Great. Okay, no worries. Just want to say great presentation. Okay, wonderful. Awesome. Well, I'm not seeing any other additional questions or hands up right now. So like Amy said, if questions come up after the fact, you're thinking about this, or you're listening to the recorded version of this on the Endo A&P website, definitely go to our Endo A&P members only Facebook page if you're not already part of that. Just look up Endo A&P members and we'll make sure to accept you into the group. That's a great place for follow-up questions. And then not only can you ask those of Dr. Amy, but then you also get the chime in of our whole community. And that's a great resource. So, oh wait, one popped up. I knew as soon as I did my closing statement, we get another question. Okay. Last thing says, I couldn't help but notice the similarities with PMDD and the increased risk for PPD with pre-existing PMDD. Can you share any clinical cases in practice that you noticed?
So from what I understand with PMDD, you actually really want to be careful with progesterone supplementation because of the fluctuations in progesterone and the GABA alpha receptor. So, I mean, I think a lot of the etiology in terms of the fluctuations can be similar. I don't know specifically in terms of treatment. I'm not 100% sure, to be honest, but I think you would definitely want to look at their hormones, but I would be a little bit more cautious when it comes to specifically hormone supplementation like BHRT. But I do think that in postpartum depression, I think there's a lot of research specifically with estradiol and progesterone. With PMDD, I would be a little bit more cautious because you can cause more of that fluctuation. From what I understand, that's essentially what triggers some of the PMDD flares. So I would probably look at it in terms of like nutraceuticals and even maybe herbs, but not necessarily looking as aggressively on from a hormone perspective, looking at replacing or anything like that. I'm always super careful with my PMDD patients because I find that it's just they're pretty sensitive and it fluctuates so much every month. So I would look at it more from like the nutrition perspective and then maybe reassess their hormones as you go. Because you can definitely do things along the serotonin pathway that we talked about.
Fantastic. Okay, great. Okay, so now we're really done. So thank you everybody for attending tonight's presentation. Enjoy the rest of your evenings. I hope everybody is keeping safe and well, and for all of those with children who are easing into whatever school looks like where you're at, good luck to you all, and we will talk to you guys soon. Have a wonderful night.
Thank you.
Good night,
Bye,
everybody.
everyone.